This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast.
All right, folks, welcome back to Alert Medic 1. Today it's just me, Mustafa. No one else is going to be able to join us today, but I'm excited to have Dr. Mike Winters come on the show. We're going to be talking about all things sepsis today. Dr. Winters, I'll let you introduce yourself.
Well, Mustafa, thanks so much for having me here on the podcast. It really is an honor to be able to spend a little bit of time talking with you and about one of my favorite topics, and that is sepsis and sepsis resuscitation. By way of a little bit of background, I am a professor of emergency medicine and medicine at the University of Maryland School of Medicine in Baltimore. I've been there a little over 2 decades, and with respect to my area of academic niche, it is in resuscitation and really caring for the critically ill ED patient. And that's really been my focus of teaching, education, and my area of clinical expertise and passion over these last many years. From a leadership standpoint, I am currently the Vice Chair for Clinical and Administrative Affairs within our Department of Emergency Medicine in the School of Medicine, which means I help our medical directors at 4 of our downtown academic emergency departments, and that includes the Medical Center downtown and midtown campuses, Mercy Medical Center, along with the VA Medical Center. So that is a little bit about me, and I am so happy to be talking about all things sepsis.
Absolutely. How'd you get into medicine? Like, what made you go down that route?
Oh, interesting question. I growing up, I actually was not interested in a career in medicine whatsoever. I played sports in high school, thought about playing sports in college. I went into college. My undergraduate training or undergraduate studies was at Johns Hopkins University. And I initially went in as electrical engineering. Midway through my freshman year, my dad actually ended up being diagnosed with cancer, and ironically was treated at the University of Maryland Medical Center, and he remains alive today, cancer-free, doing well. And I think that started a pivot for me towards interest in a career in medicine. Hopkins has a relatively robust biomedical engineering program, and so I switched from electrical engineering to biomedical engineering during my undergraduate years. I completed a degree in biomedical engineering and then not only applied for graduate studies there, but also for medicine, as I started to think I was a little bit better at the bedside than in a lab, and just opportunities arose that allowed me to pursue medicine. And here I am. There's also a little bit of a pre-hospital add to that, in that my dad was Maryland State police officer, and his career within the Maryland State Police actually was on the medevac helicopter. And he was at the start of our shock trauma center when he would bring patients into our Adams Cali when the helicopter needed to land on the parking garage that no longer exists, and then they would race down in the EMS unit to come over to trauma. And so he was there at the start, and I think that somehow is a little bit of a connection really to not only Maryland from his cancer treatment, but Maryland from the shock trauma center and his pre-hospital involvement that really steered me towards emergency medicine.
I did not know that. That's really interesting. So he must have been there right when Cali got his initial grants and everything. And wow, I bet he's got a lot of really interesting stories to tell.
So many stories that we recant from time to time talking about work.
Yeah. Wow. So in terms of, emergency medicine, what pulled you towards like the world, the interest of resuscitation and sepsis specifically?
I think it's really the combined IM component. So University of Maryland, the Medical Center, in terms of our residency and training programs, we are one of only a few in the entire country that has not only categorical emergency medicine training programs. We also have EM and IM combined, EM pediatrics combined, and then we also have an EM IM critical care triple residency tract. And we actually may be only one of 2 centers in the US that does that. And I think as I progress through residency and the IM component and rotating through the various ICUs and also the trauma component and rotating through the trauma ICUs, really I gained a passion for resuscitating critically ill patients, no matter what that may be. It could be sepsis, it could be cardiac arrest. I love taking care of cardiac arrest and the post-arrest patient. Really is in addition to sepsis and other critical illness states. It's just where I have found my home. And when I'm working clinically in the ED each week at the downtown campus, I much prefer that critically ill crashing patient to be able to step in, intervene, try to figure out what's going on and try to administer any life-saving procedures or therapy.
Yeah, the high risk measured calculus of resuscitation. Yeah, no, certainly similar things attract me to EMS. Showing up where certainly the scene is may or may not be stable, and having a limited set of tools and a limited team that you may be unfamiliar with, and being forced to resuscitate someone that's very sick. So no, I can certainly appreciate that.
I would say that in the ED, I have great respect for our EMS and pre-hospital providers. It's not a scene or scenario that I'm used to. I have no training in it whatsoever. You bring me patients pretty well packaged, and so it allows us to continue that care, but you have my utmost respect for what you encounter really on the scene. I don't know that I would be able to function in that environment.
Yeah, and I'll tell you what, as someone who doesn't ride in the field full time anymore, I have the utmost respect for folks that continue to do the work, right, through a pandemic, through staffing shortages, and through really sick people coming out after the pandemic, the realities that EMS has to deal with, and certainly it's so appreciated when folks at the in the hospital appreciate that as well. So. Let's transition to sepsis. So, let's just define it first. In simple terms, how would you define sepsis?
So that is a very interesting question that has evolved over several decades. We started way back when with sepsis 1, then we evolved to sepsis 2, and within the last 8 to 9 years, we've got sepsis 3 from a definition standpoint. And this was published in the mid 2015, 2016 timeframe in Journal of American Medical Association, whereby they put forth a new definition of sepsis. And currently, how would we define it? Well, strictly speaking, it's a life-threatening organ dysfunction caused by a dysregulated host response to infection. So this is really getting at the body becomes infected with an organism, and there is a release of a whole lot of cytokines and a number of chemical mediators that in that individual patient leads ultimately to organ dysfunction as a result of that infection. And that's really what this current sepsis definition tries to capture and characterize.
Got it. And I'm going to try to explain my understanding of the steps of sepsis, and then maybe you can fill me in where I'm incorrect or maybe lacking detail. So, for whatever, and we'll talk about the sources of, infection and sepsis. So there's some sort of pathogen that shows up, and your body recognizes it through pattern recognition, that it does not belong to self. So it starts an initial, response to that, immune response to that ultimately, in the specific story of sepsis, causes a series of steps that then causes an exaggerated response, that then results in, the symptoms that we'll see that we'll talk about as well. Did I get anything wrong there?
No, I think that's a nice way to describe it. I think you have a good understanding.
Okay. So let's talk about the top 5 sources of sepsis, because when we were talking on the phone planning this thing, I loved how you put them, and I'd like to talk about that.
Well, if you allow me to, let me back up just a little bit and stay on the definitions for a moment, just to provide, I think a lot of your listeners are very familiar with what's called the systemic inflammatory response syndrome. And when patients encounter an inflammatory stimulus, sepsis does tend to be one of the most common, but we have that SIRS criteria, whereby there's tachycardia, there's tachypnea, there's a febrile illness, or someone's hypothermic. We really don't have the ability to test for white blood cell count elevated or leukopenic in a pre-hospital or EMS setting, but you've got 3 of those 4. In terms of sepsis and leaning back to prior definitions, if patients display at least 2 of those, you need to be concerned that the patient may have sepsis. That could be tachypnea and a fever. It could be tachycardia and tachypnea. Any 2 of at least those 3 that you're able to measure, at least start thinking, could this patient have sepsis? Now, that systemic inflammatory response syndrome is seen in trauma. It's seen in other acute illnesses, such as even pancreatitis. So it's not specific to sepsis, but when you encounter someone with tachycardia, tachypnea, fever, or they're cold, conversely, they're cold, think this could be a sepsis alert type of patient. Once we have a strong suspicion or a confirmation that there is an infection in the presence of an inflammatory response, then we're thinking, okay, this is sepsis. And then once we've moved on to sepsis-induced hypoperfusion, patients are hypotensive, then we start thinking, could this be a septic shock type patient? Importantly, included in those initial recognitions is not hypotension. So hypotension alone isn't a requirement for sepsis. Patients can still have sepsis and be normotensive and sometimes even hypertensive. So I wanted to just point that out as a pearl and or a pitfall. Now, when we think about where could this patient have an infection, we think really there's the top 5 locations for sepsis. By far and away, number 1 is pulmonary. A pneumonia, and that pneumonia could be bacterial or even viral, say such as COVID-19 is a viral illness. But your number 1 location for sepsis across the board is the lung. So be thinking, is this patient at risk of having some pulmonary process? Are they tachypnic? Are they hypoxemic? Do they have a fever or conversely hypothermia? That's by far and away, if you were to answer a multiple choice on a test, it's pulmonary. Followed by genitourinary. So urine sources are the second most common source of sepsis, followed by intra-abdominal. So this could be gallbladder, cholecystitis. This could be appendicitis. This could be really severe diverticulitis or ruptured diverticulum, and they've got an intra-abdominal abscess. GI sources are the third most common, followed by skin and soft tissue. So you've thought about lung, could this be urine, could this be some belly source? Look over their skin. Do they have signs of a cellulitis, a soft tissue infection such as an abscess? The other area where overwhelmingly sick septic patients can have skin and soft tissue infection is in necrotizing fasciitis infections. So really taking a look as best you can in that setting to look over their skin and soft tissue. And lastly, something that we don't think about as often is actually indwelling lines or devices. And that may be someone who is receiving chemotherapy for cancer and they've got a PICC line in their right bicep that, unless you take a look, take off their shirt, that you may not know that. That is, once again, the top 5. The 5th most common source of sepsis could be a PICC line, could be a midline, could be a portacath that they have, could be a dialysis access catheter, or even some other indwelling device. And more frequently, I think your listeners are picking up patients from home that have ventricular assist devices or VADs. You know, that sepsis tends to be one of the most common presentations or the reason why a VAD patient needs to be brought into the emergency department. So once again, look in the lung, think about the lung first, genitourinary, intra-abdominal, skin and soft tissue, and then lastly, what indwelling devices or lines do these patients have?
You know, I found it so eye-opening when we talked about this on Friday, because my framework and how I was taught and how I continued to think until Friday was usually rooted in a couple things. Number one, it was like the GIGU, right? Mainly the like indwelling, like a catheter or something, right?
Mhm.
Like a suprapubic or something like that. But then also the any sort of ports and casts and stuff like that. So when you said that, that was like the fifth rung of this ladder. It was eye opening to me because and the fact that the lung, right, the pneumonia, the respiratory system being the number one cause, that was very eye opening to me, and I think it'll be eye opening to our listeners. I had a question regarding just in the stepwise approach that we talked about before about the steps of sepsis, for lack of a better term. So the localized infection would be just a pneumonia, right? I mean, I say that in quotations with quotations, but what steps occur from a localized pneumonia to a systemic sepsis? Like, what are the actual steps that occur in that process?
Mm-hmm. It's wonderful. Another wonderful question. Let's just say someone has a bacterial pneumonia process. They've got a right lower lobe pneumonia, right middle lobe pneumonia. While that infection is necessarily contained in that area, the bacteria, whatever pathogen may be there, understand that the body has its own inflammatory reaction to that pneumonia in that location. Cytokines and all sorts of inflammatory mediators are being sent out systemically throughout the body. And it's that, once again, leaning on the definition, dysregulated host response that starts to create organ dysfunction. So while you've got a right middle lobe pneumonia, this sort of cytokine release, inflammatory mediator release, then starts to affect kidneys, let's just say. And patients develop acute kidney injury as a result of this inflammatory or dysregulated host response to their simple right middle lobe pneumonia. Not only could this cause kidney dysfunction, but shortly we can touch on cardiac dysfunction and how that may play into resuscitation. A large number of patients with sepsis may have a sepsis-induced cardiomyopathy or sepsis-induced cardiac dysfunction whereby their ejection fraction is now lower, and we would need to think about that and look for that and think, how does that change our management with fluids and our vasopressor therapy? So it's this release of all of these inflammatory mediators that start to negatively impact other organ systems. Kidneys are a big organ system that usually takes a hit in sepsis. Cardiac, if it's not a pulmonary source, and it's one of the other ones that locations we talked about, the lungs can also be adversely affected. Even the coagulation system can be negatively affected by this response to the patient's localized infection. So it really is systemic. The longer these patients go without recognition, without identification, and without appropriate resuscitation, the more likely it is that this inflammatory reaction of the patient's own body starts to result in multi-organ dysfunction outside of the actual location of where the infection is.
Great. And I wanted to go back to the SIRS criteria you were talking about before. So just for our listeners, we're not now, just for a moment, I want to step away from the sepsis topic and just talk about the SIRS that you were talking about. And you said that those symptoms can occur in trauma. They can be, can occur in other disease processes. What's the common denominator, not necessarily in the cellular messenger of cytokines and stuff like that, but from the body's perspective? Is it like the endothelial damage? Is it, what occurs that then causes the release of these factors that then cause the SIRS?
Mm-hmm. It's fairly complex in terms of the immunomodulatory, immunoregulatory, essentially the immune system recognizing the pathogen. I think you're correct in saying endothelial dysfunction as well. A lot of things are occurring in either a post-traumatic and post-inflammatory, a septic patient that make it hard initially to tease out what's going on. But it is just that overwhelming release from T cells, from the endothelial cells, lots of pathophysiology behind it that I tend to have a monotone voice, and I don't want to put our listeners to sleep as we're talking here about the complex physiology of T cell immunology.
Yeah, no, that's fair. I'm usually the person that puts them to sleep, so no, I get it, and that's just it's just interesting to me, teasing out those minute details that end up having so much more of an impact. But no, that's fair. Maybe me and you can have that discussion offline. So, all right. So we've talked about the sources of sepsis. I think that was, at depth, very interesting. Let's talk about, and this I do want to get into the details of the pathophysiology of each of the symptoms that we see with sepsis. So, in Maryland, for folks that may not be from Maryland or maybe listening from our international community, Maryland has you have to have a source of infection. And you have to have two of the four symptoms that I'm about to say. So you either have to have fever, tachycardia, hypotension, or, and this one's combined, tachypnea, which is defined as a respiratory rate greater than 22, or a low end tidal. So if you have two of those criteria, your patient qualifies as a sepsis alert, and we have an alerting system in Maryland where we'll call the receiving hospital and let them know what we have coming, and then there's a series of steps that we do to treat them in the pre-hospital setting. So I wanted to go through each of those, Dr. Winters, and talk about which step in the disease process, and we can nerd out on this because that's what we do. What step in the disease process causes each of the symptoms and what's actually happening? So if you don't mind, let's start with the fever.
Absolutely. And these are the pyrogenic cytokines that are released, are essentially elevating the body's temperature. And there have been a number of studies in the critical care literature over the past 10, 20 years that have looked at and have questioned whether we should actually be treating fever in the setting of infection. Perhaps that's the body's response and in an attempt to combat the pathogen that is now infecting the host in essence. In that when we treating fever, does it help? Certainly it's patient-centered in terms of alleviating discomfort and the elevated temperature, but is it really the right thing to do to treat fever? I'm going to put that aside. But it really, it's the pyrogenic, as I mentioned, cytokines that start the temperature elevation. Within the pathophysiology of sepsis, I alluded to this a moment or two ago. In general, I'd like you to think about sepsis as a vasodilatory type of shock or critical illness. In other words, as a result of this inflammatory milieu, what happens in sepsis? Well, there is pathologic vasodilatation, and that can be arterial and venodilatation. There is increased vascular permeability. And so there is an overall relative intravascular volume depletion because of that arterial and venodilatation from sepsis. In addition, you have, as I mentioned, many patients with sepsis, and the longer it progresses and the more severe it becomes, they develop a sepsis-induced cardiomyopathy, so their ejection fraction is suppressed. Any critical illness or shock-like state is really defined as inadequate oxygen delivery to meet tissue demands. And so in the setting of sepsis, in the setting of pathologic vasodilatation, increased vascular permeability, maybe lowering of the contractility or ejection fraction of the heart, the organs and the tissues are seeing decreased perfusion, decreased oxygen delivery. So you may see hypotension as a result of the vasodilatation and the relative intravascular volume depletion, the relative decrease in their ejection fraction, and the body's compensatory mechanism of tachycardia to increase stroke volume, to, in essence, not increase stroke volume, but increase heart rate so that cardiac output is maintained, and subsequently O2 delivery is maintained to the tissues. So I think that the temperature elevation or subsequently hypothermia is directly related just to the infection. But the hypotension is seen from the pathophysiology. The tachycardia is the body's compensatory response to maintain a reasonable cardiac output. The tachypnea, that could be for several reasons. Once again, lung is the most common source of sepsis. And so just from the pneumonia alone, patients may be tachypnic. They may be hypoxemic because there is, depending on the severity of the pneumonia, there's decreased O2 diffusion across the alveolar membrane. And so that may be why they're hypoxemic, maybe why they're tachypnic. Another reason why the tachypnea may be present, or your lower end tidal CO2, is many septic patients are acidotic, so their pH is lowered, and the compensatory response to a lower pH is to decrease your PCO2 to create a respiratory alkalosis to bring that pH back up. And so that tachypnea, while it could be due to a lung source, may also be a compensatory mechanism given the acidosis and the acidotic milieu that sepsis, in other words, creates within that patient. So hopefully that seems reasonable as an explanation why we see many of these vital sign abnormalities in patients with sepsis.
Yeah, no, certainly. And we've talked about at length on the show the basic function, or what goes into a patient's mean arterial pressure, right? So we talk about the cardiac output and the systemic vascular resistance. I've talked about it in terms of a story that my first ever job was. My dad was a mechanic, and he worked at a used car dealership. And my first job ever was detailing cars at the dealership he worked at. And how I always talk about it is like, so the hose that I had to wash the cars with didn't have a nozzle. So what did I have to do to increase the pressure? I would have to put my finger over the tip of the hose, and that's how I always explain the Ohm's law, right? So, or the idea of pressure being a function of flow and resistance. And again, we've talked about it at length on the show, but just to reiterate, in terms of sepsis, from what I'm understanding, from what you just explained, was this: there's a primary damage to that systemic vascular resistance that reduces SVR, right? And we understand basic multiplication, any cardiac output and systemic vascular resistance. If any one of those goes down, the total blood pressure of the patient goes down. And as the disease progresses, that's when we start seeing variables in the cardiac output go down, specifically the stroke volume goes down for the reasons that you explained, which then in turn causes your body to try to increase the heart rate to compensate for that reduction. I think this is important for our listeners to understand, and it might be helpful for, if you're a bit lost, to go, we'll put in the show notes. We'll put my description that I just said and Dr. Winter's description in the show notes. But it might be helpful to pause this and rewind just to listen to Dr. Winter's explanation again, because I think it's relevant when it comes to the treatment and what we see in terms of the treatment. Did I explain that correctly?
Yeah, I think that you did a very nice job.
Okay. So we talked about the major symptoms. When do you think we should talk about lactate? Do we think you should later, or do you think you think we should talk about it now? What are your thoughts?
We can go there now.
Okay, perfect.
In terms of lactate, what I think is important to know is that lactate is nonspecific for sepsis. That there are long lists of what causes an elevated lactate. And this could be a type A lactate that could be due to hypoperfusion. This could be a type B, B1 or B2 lactate, which is not reflective of hypoperfusion, but rather another mechanism. Could be beta agonists, could be catecholamines, could be medications such as metformin in a diabetic. So lactate is not going to say this is sepsis. You got to think critically and carefully. Malignancy can even elevate your lactate. Liver dysfunction can elevate your lactate because 80% of lactate is metabolized in the liver, the remaining 20% in the kidney. So renal disease, hepatic disease, medications, catecholamines, all of them can elevate your lactate. What we do know, and what I can reasonably say for sepsis, is that trending lactate, when your initial lactate is greater than 4 in the setting of sepsis, study after study has associated that with increases in mortality. So we can say that there is a link with elevated lactate, likely due to hypoperfusion in sepsis, that identifies that patient as high risk or having higher mortality. We trend lactate values in sepsis resuscitation, and we want to see, especially if it's north of 4, it continues to come down. But what I would caution all of us from getting in the habit of, if it's an elevated lactate, give them more fluids. Elevated lactate, give them more fluids. Still high, give them some more fluids, because that may not be the answer. And if we think about that individual patient, perhaps you've just given them a neb, or they've got their end-stage liver patient who may not process that, and they've got something else going on. Well, we're headed off in the wrong treatment algorithm for that individual. Definitely it's associated with higher mortality, but it's not exclusively related to sepsis.
I learned a lot just there because I knew that lactate wasn't specific, but I didn't know why. So I appreciate that explanation. I want to go into a little bit sepsis scoring, because I'll be honest with you, this is something I know nothing about. I mean, I know the terms like SOFA and QSOFA, and I feel like I've heard a million others. I was hoping you could help us, understand, like, for example, what scores you all use in the hospital setting and what your thoughts are on the various scores and what you prefer. From my understanding, there is no perfect score, which, I mean, of course, is natural to medicine, but I just wanted to get your thoughts.
It's great, and we can expand upon this however you want to go. And I'm going to point all of us, all of your listeners, to a recent article that was just published in the Annals of Emergency Medicine that we should put the link in the show notes for everybody to click on. And what this study looked at is clinical gestalt, or physician gestalt. Now we're set in an ED setting here, so go with me on that. And compared it to established early warning scores. And they looked at SIRS. In other words, SIRS criteria, did you have 2 or more? They looked at something called the National Early Warning Score, NEWS. They looked at the Modified Early Warning Score, MUSE. They looked at QSOFA, which came out at the time of the Sepsis 3 definitions and publications as a way to identify patients at higher risk of inpatient mortality. They also looked at SOFA, and they looked at that institution where they studied their own sort of homegrown machine learning algorithm. At the end of the day, at the first 15 minutes of patient evaluation and at the 60-minute mark of patient evaluation, do you know which one of those scoring systems fared the highest?
I'm just going to go ahead and guess and say neither. And they were all the same. Or, I don't know. My gut tells me that the provider one ended up scoring out the best. But I don't know. I have no idea.
And you would be correct. Physician gestalt turned out right now to have the highest area under the curve for identifying someone with sepsis. Now, each study has its own limitations, and granted, that particular study looked at sick patients coming in, so they already kind of parsed out a higher likelihood of critical illness in that group. But when we talk about, what scoring systems do we use, I think everyone listening to this should understand that none has been shown to be superior than any other, and that each organization can choose to follow. Right now, SIRS can follow NEWS or MUSE. I will say that there's a reasonable amount of literature since the Sepsis 3 publication that has shown that the QSOFA scoring system doesn't compare well to these others. And in fact, I believe the latest iteration of the Surviving Sepsis Campaign guidelines no longer recommends QSOFA as a screening tool. I do think in the coming years, as AI gets better and as we continue to learn more, there will likely be a scoring system. It may not even be described yet, but I think that we are headed in a direction where AI is going to help us. And once again, each institution has its own sort of learning algorithm, its black box of variables that it dumps in and says, okay, this patient's at high risk for sepsis. But if you feel stressed about not knowing the criteria under SIRS or Muse or News or SOFA, it's okay. It's easy to pull these up on any type of app to roll through and take a look at, but understand at this point in time, Friday, October 4th, 2024, when we're recording this, there is not a single early warning score that has been shown to reliably and routinely identify patients with sepsis. And that as we sit here today, doing this recording, still physician and provider gestalt fares better than the established scoring systems.
That's really, really interesting to hear, and we're definitely put the link to that paper in the show notes. If you don't mind just sending that to me, and we'll do that. That's really interesting to hear because, well, first it's interesting because you said the patients were cohorted, right? So it was like pretty sick patients. I'm assuming the answer is no, because you already said there is no score that is really that good, but has there been work done for those like early patients that like will eventually become sepsis, right? Septic, severely septic or septic, and any tools that help with that, or even, is that even less of a, reliable thing?
If we look at just all comers to EMS in an emergency department, it's super hard to tease out. And that's why a lot of these scoring systems have overall lower sensitivity. So still nothing that's really reliable. Here's what I would say to that. And I don't have any easy answers for all of our listeners. We do know that patients who go on to have a sepsis diagnosis, up front, if they present with vague, nonspecific symptoms, and there's that delay in diagnosis, they do have higher mortality. And so very much like when I mentioned if someone's tachypnic or tachycardic, starting to think that this could be a septic patient, those with very nonspecific complaints, generalized weakness, fatigue, maybe altered mental status. If that's due to sepsis, at least start to think, could this be an infectious etiology for those generalized complaints? Because if it is, those are the patients that are at higher risk of or increased risk of mortality, because we don't have that cough or productive cough or the red leg that's markedly cellulitic to say, let's just pull the sepsis trigger and off we go with treatment. It's those non-specific complaints that you really have to have a very low threshold for considering sepsis. And to that end, now I'm speaking about emergency department literature, but we're all in the same space. If I were to take every critically ill patient that lands in my emergency department, statistics would say roughly 60% of the time, it's due to sepsis. So it's a little bit better than a flip of a coin. If you're coming up on a critically ill patient and it's a non-traumatic patient and they look really sick, they look ill, it could be a number of things. But more than half the time in a critical illness in a non-traumatic type of setting actually is going to pan out to be infection or sepsis. So having that higher suspicion, lower threshold to say that this could be an infectious etiology really stands to improve patient care and patient outcomes. And if you were to ask me, and I know we're getting back to vital sign stuff, the one vital sign abnormality that makes me very apprehensive and has been shown to have the greatest association with critical illness, it turns out to be tachypnea. I know that when we look at vital signs, we're going to say 18 or we're going to say 20 because they don't look tachypnic, but it behooves all of us to take a minute and count the respiratory rate. And if they are truly tachypnic, be worried, because that's the one vital sign that has the strongest association with critical illness.
Yeah, so many great things are. So first, for the tachypnea, for ALS providers, we have the waveform capnography to utilize. That gives us a very accurate, strong, and trending value for the respiratory rate and the end tidal. So that's very interesting. Where was I going to go with this? I had a very interesting thought that I just completely blanked on. It's all good. In terms of so when you talk about the tachypnea, when do you? Man, I really had a very compelling thought, and I just had a brain fart. Man, that's crazy. All right. Well,
I took you on a detour, but we were focused on scoring systems that, if you need to think about it, it's easy to pull up on your device. But know that still every one of them has limitations, and they haven't been shown to outperform your clinical judgment at the bedside.
That's where I was going. So, in the world of EMS, we're getting all these cool tools, right? I mean, I just mentioned end tidal. I would argue that's not really. I mean, it's a cool tool, but it's not really that cool, right? But we get all these cool gadgets and toys. But I can't help but stress enough the utility of basic medicine being the foundation of what you do on the everyday basis. And what do I mean by that? I mean getting a good history and performing a good physical exam. Because especially in these early patients, right? These patients that are pretty early, you show up to a nursing home and maybe they're on, I don't know, 2 liters nasal cannula with like 50 feet of cord, right? Or tubing. And the patient is alert and oriented, but they just feel off. Getting a good history and trying to figure out how long they've been feeling this way, if they've had any recent procedures done, if anything like that will, I think, help increase that clinical inertia that we're working on in our heads to figure out, hey, this might be a sepsis patient, which then would lead us to doing things like taking a temperature and so on and so forth, which maybe if you don't do that good history taking, you don't have that switch get flipped in your head to, hey, take a temperature, do all these things. And then also with the physical exam, like you mentioned before, looking for and it doesn't necessarily just have to be a nursing home patient, looking for maybe signs of IV drug use with that early cellulitis, right? And looking for, if the patient's altered, looking for surgical incision sites, looking for ulcers, things like that. That really, I think when we got to do the basics really well, even before we start getting into these tools, so that we can catch, I think most folks are going to catch the 80%, right? It's the 20% where we miss. I think if we get really good at the basics, that's really what helps us improve on that 20%, and catch the folks that otherwise might have a negative outcome. Did you have anything to add to that?
No, I really like the way you said that, and coming back to basics, when you start to see some vital sign abnormalities, be also wary about hypothermia. That tends to higher risk of bad outcome than hyperthermia. But nonetheless, you're starting to get a sense, could this be infection? Just think, is it lung? Are they tachypnic, hypoxemic? Listen to them, and do you hear focal breath sounds, rhonchi, on the right or left side? Could they have a genitourinary source? Do they have an indwelling Foley? Press on their belly. Is it tender? Is it peritonitic? Is it rigid, etc.? Thinking about an intra-abdominal source. Look them over for skin and soft tissue. Look them over for any indwelling lines or devices, and you're going to capture really the majority of patients by just having that sort of systematic approach. And scoring systems, sure, we'll get better. We'll use AI. There'll be a few more that come out in the coming years, and we'll take a look at those and see if they're beneficial. We'll continue to screen and trend lactates, in someone who's has sepsis-induced hypoperfusion, and we'll follow those and know that they're associated with mortality, but doesn't mean that we reflexively give fluids and other things that we could get into if you want. But thinking about the basics and getting the pertinent history to the extent that you can, it really goes a long way.
Absolutely. So we've walked around the treatment discussion here for a bit. Let's get into it. And before I forget, there's three things I want to talk about. I want to talk about all the treatment, especially what occurs once we place a patient, at the emergency department. But three big things I want to talk about is fluid choice.
Mm-hmm.
I want to talk about pressor use and pressor choice. Including the pharmacology of each that we would use in the pre-hospital setting. And then I also want to talk about everybody wants to use antibiotics pre-hospital, and I'm not a huge fan of that. So I want to talk to you about that.
Mm-hmm.
Before we get into the specifics, I'd like to talk to you about your approach to a sepsis patient after you've confirmed, yes, I think this patient has sepsis.
Mm-hmm.
What are your initial treatment priorities, and where do you go from there?
Sure. So I think of sepsis in a few different columns or buckets, whatever your word is of choice there. Early recognition, early and appropriate antibiotics, appropriate fluid resuscitation that may or may not necessitate vasopressor administration, source control, and then any other type of specific therapy, and that could include corticosteroids at some point. Let's just say we've moved beyond the first bucket. We've identified them as this is someone who we know has sepsis, or we're strongly suspicious of sepsis. I think I can't envision a place now that doesn't have a sepsis order set, whereby we're going to just enter those orders, and that's going to comprehensive metabolic panel, what's the patient's kidney function, because while it won't affect the first dose of antibiotics, it's going to affect our dosing of second and third and subsequent antibiotic dosing. What's their liver function? What's their electrolytes? What's an overall acid-base gestalt by looking at their CO2? Do they have an elevated anion gap? So you're looking at that from a chemistry standpoint. Getting your cultures are important prior to antibiotics. Sure, getting the lactate, getting a venous blood gas to see what their pH is from an acidotic standpoint are some critical things. And knowing that the lung is the most common, we're going to get an x-ray followed by genitourinary. We're going to get a urine with a reflex culture. And then we're also going to drive any other testing based upon what you see on exam. Could they have neck fash due to intravenous drug use? We're going to get imaging of that extremity. Are we worried about the belly and they need a subsequent CT of the abdomen? So a lot of that is driven once again by our careful exam. If you were to ask me what's the most critical intervention, to me it's the right antibiotics in a timely fashion, along with timely source control for those that need source control. So before we get to fluids and pressors, antibiotics are a critical step in the resuscitation of sepsis patients. There is a push that has been present for many years and continues to be reemphasized by national regulatory bodies such as CMS and the Joint Commission from a hospital standpoint that really drill down to say, how quickly are you getting antibiotics in someone? Acknowledging that there are those regulatory requirements, I think it's very important to reiterate that where does antibiotics as soon as possible make a difference? It's really in the septic shock patient. So those that manifesting septic shock due to sepsis, that's when you want to get antibiotics on board, ideally within the first hour. Beyond that, this push to get everything done for all comers with sepsis in an hour is not evidence-based. It's really most beneficial in the septic shock patient. Now, with respect to antibiotic choice and why, depending on someone's transport time in the pre-hospital system, is it probably best to have them administered relatively soon after ED arrival, is because I'm going to borrow a phrase, you want to choose wisely. And that the right antibiotic for that patient is dependent on the hospital's antibiogram. In other words, what are the local organisms, or what are the organisms circulating in that community what are their sensitivities to certain antibiotics. So the antibiogram is key. The patient themselves. So what prior infections have they had? What have those organisms been? What resistance to antibiotics, or what antibiotics is that patient's prior history resistant to, in order for you to choose wisely? All of that stuff is unlikely to be present at your fingertips in the pre-hospital setting. And it also depends on the most likely source. So you're going to choose antibiotics and you're going to focus on getting them in early, but it needs to be done in the context of that patient, what their prior infections and sensitivities have been, what the current local antibiogram is telling you, and what's the most likely source. Because if it's a pulmonary source versus an intra-abdominal, you may be choosing different antibiotics based upon the organ or the location of infection. So that's what I would say around antibiotics. Hopefully that's helpful. Let me stop there before moving on to fluids to see if you have any follow-up questions.
Yeah, no, that's very helpful because it provides insight on why there's been hesitance, right? So from my understanding, it was always a couple of those things that you mentioned. Number one, what drug are we what bug are we attacking, right? Which certainly is important. And then also the back end cultures have to be still conducted, right? So and for folks that may not be familiar, what that means is there's blood samples taken, right, or samples taken from wherever the source is, and then those microorganisms are then grown and then identified in a lab. So that helps us understand exactly what we're treating, because depending on some of the characteristics of these bacteria or whatever, there's going to be different tools to do the job. And these things are various characteristics of like their like cell walls and all kinds of stuff that we don't need to get into, but that's what we mean when we say cultures. And from my experience, the capturing of blood in the pre-hospital setting has many limitations, not the least of which are logistical limitations. Meaning that the blood tubes that you have to use have to be specific to the lab of the hospital that you're taking the patient to, number one. Next, the technique has a bit of finesse to it, where if you don't draw the blood sample correctly, it's going to coagulate and you're not going to have a viable sample, which would I would argue be disastrous, because say you gave a broad spectrum antibiotic after getting a sample and now that sample is corrupted, we may never know what the actual initial sentinel bug was, correct? So there is concern of that. So I think those two things, coupled with everything else you said, certainly describes why pre-hospital early antibiotic administration, even in the shocky patient, may not be the best until those parameters are met. And certainly in the world of technology and everything like that, I think I'm not saying it's never going to happen. I'm just saying that there has to be a few other systemic improvements done before we can take that step.
Yep. Very nicely said.
All right, let's keep moving to, you want to get into the other treatments?
So let's just talk about fluids and maybe the need for vasopressors for a moment. With respect to sepsis and also bringing back in the regulatory bodies and sepsis, let me think of the right word, sepsis criteria per se, and treatment, regulatory body recommended treatment. Fluids is going to be central to that. Now, in general, you'll see recommendations for a certain quantity of an initial fluid bolus. Importantly, those recommendations are for 30 milliliters per kilogram of ideal body weight, or per kilogram, let's just say that, in patients with sepsis-induced hypoperfusion. That doesn't mean every septic patient gets 30 mLs per kilogram. you want to have evidence of sepsis-induced hypoperfusion. Could be altered mental status, hypoperfusing the brain. Could be cool mottled extremities. They're not necessarily going to be cool because it's a vasodilatory state of shock or type of shock. But nonetheless, you're seeing poor peripheral perfusion, maybe altered mental status. You won't necessarily get this right off the bat, but maybe they've not had any urine output. In someone with sepsis and there's signs of hypoperfusion, then the guidelines would recommend 30 mLs per kilogram of an isotonic crystalloid. We've kind of pushed back a little bit on that over the years because not all patients benefit from that degree of fluid administration. I will be honest, many can tolerate it, but it doesn't mean that they benefit from it. And really kind of uncertain where this 30 mLs per kilogram came from because the initial studies looked at 20 mLs per kilogram, and then all of a sudden we see 30 mLs per kilogram recommended in guidelines. In more recent iterations of the Surviving Sepsis campaign, they've pulled back on recommend that fluid amount to now simply suggesting. So they've weakened their recommendation on that degree of fluid. And the regulatory agencies within the US that take a hard look at sepsis measures and metrics, they've also given the provider the discretion of not to administer this degree of fluids in certain patient populations. And those are those with end-stage kidney disease, also significant cardiomyopathies and poor ejection fraction. Those patients tend to more often poorly tolerate that fluid amount. Not all comers, I mean, some can, and most will be okay with initial 30 ml per kilogram bolus, but simply know we don't want to just check the box and give every single patient that degree of volume. What would I recommend in the pre-hospital setting from an amount? I think, in someone with sepsis-induced hypoperfusion, if you wanted to look at 30 mLs per kilogram, that's probably okay to get started, and that nearly all will tolerate it, even in the setting of renal disease on hemodialysis. In the absence of sepsis-induced hypoperfusion, you can administer fluids, but you don't necessarily need to do this 30 mLs per kilogram. I think it's very reasonable, and if you're concerned that the patient may poorly tolerate fluids, you have it on their history, CHF, and you see the ejection fraction at 10 to 15%, that's not someone to give liters of fluid to. I think you can very reliably provide 500 mLs, and then what's going on with the patient? If you're in an EMS setting that you've got a prolonged transport time, give an initial 500, reassess, give another 500, reassess, give another 500. Are they becoming tachypnic, hypoxemic? Do you now hear rowels at the bases whereby they're tolerating that poorly? Then you can pull back. But I think just knowing the background of where that quantity came from, if they're showing evidence of hypoperfusion and or shock, it's reasonable to give that, and most will still be okay tolerating that. But short of that, thinking about judicious and appropriate fluid administration and individualizing fluid administration is really the smart way to go. Now, let me talk just briefly about vasopressors. And in someone who you're seeing they've got sepsis, they're hypotensive, sepsis-induced hypoperfusion, you're going to start fluids, but they may have a woefully inadequate mean arterial pressure, whereby you may want to start fluids and pressors concomitantly to make sure that you get an adequate mean arterial pressure in that 65 to 70 millimeters of mercury range. We very readily now start peripheral vasopressor administration. I think that we've proven that that's a safe practice, provided that you've got a good functioning IV, usually not in the hand or distal forearm where there could be risk of extravasational injury. but we're very used to now starting peripheral pressors. The recommended vasopressor of choice in the setting of sepsis is norepinephrine, followed by vasopressin if they're not responding to norepinephrine. But I would think that from a pre-hospital standpoint, you're starting off with what you feel is the right amount of fluid, may or may not be starting pressors concomitantly with that, and starting norepinephrine peripherally and then titrating it up. I think at that point in time, you're probably at your destination whereby you'll be able to hand off, and then if need be, we would think about adding a second pressor for those not responding. Once we move to thinking about a second pressor or getting at moderate high doses of norepinephrine, that's when we'll also think about ordering or administering a corticosteroid, usually hydrocortisone, and now possibly fludrocortisone in addition to hydrocortisone. But we're a little bit into the patient's resuscitation, whereby you've handed off to your emergency department colleagues. Let me circle back to one other thing, and then I'll pause, and that is type of fluid. I very much like to administer a balanced crystalloid and not large volumes of normal saline. We know large volumes of normal saline induce a hyperchloremic metabolic acidosis, and most of these patients are already acidotic. Is 1 or 2 liters going to make a difference? And do you need to switch your type of IV fluid in the pre-hospital setting to a balanced crystalloid if you're going to give 1 liter, maybe 2? Probably not. And the literature over the years, I still think in the setting of sepsis, a balanced fluid is a better choice. But are there those in the camp that it doesn't make a tremendous difference and you're probably okay doing normal saline initially? Yeah, probably. My personal practice is the administration of balanced fluids, but I can't fault you just for sticking with normal saline and giving that first liter in 500 aliquots until you get to the destination ED.
So what is your fluid? I mean, is it an LR? Is it like what would you prefer to give?
Well, if you look at balanced fluids in general, probably the most physiologically neutral is lactated ringers. What do I use? I tend to use a plasma-like product. Now in my emergency department, we've got all three, from an LR, normal saline, and a plasma-like product. I tend to do more of the plasma-like product than LR. And that is me.
Got it. So it's interesting. I have a few questions. So first thing I thought of was when you were talking about the large volume fluid resuscitation, so specifically the 30 cc per kilo, you had the frame of septic shock instead of just the simple presence of 2 of the 4 symptoms we talked about. Because what I'm thinking about is what patient I'm thinking about is the febrile patient that is tachypnic, that technically meets our criteria, but is not necessarily that shocky that we then overload with fluids. And I believe you mentioned that's not that big of a deal in a patient that is shocky, right? But in patients that are not necessarily as sick, that's a very interesting point you made. In those patients, are we then going for what targets are we going for then in terms of fluid resuscitation, if any?
Yeah, so just a few clarifying things there. In someone that you have with sepsis, what I would say is key in on sepsis-induced hypoperfusion. If they've got sepsis-induced hypoperfusion, that's where the recommendation of that large volume fluid bolus comes in. And if you have someone with hypoperfusion that you think is due to sepsis, giving that large volume fluid bolus is likely going to be tolerated by most. But I say that meaning, or with the importance of emphasizing that it still should be individualized to that patient. But if we just assess all comers, most with sepsis-induced hypoperfusion, even with those significant comorbidities will probably be okay tolerating that degree of fluid. In the absence of sepsis-induced hypoperfusion, to me, you want to think critically about the patient lying in front of you as to what degree of fluids they need. You do not need, in the absence of sepsis-induced hypoperfusion, to feel compelled to give all of that volume.
Yeah, and just for a bit of perspective, I was just thinking about our sepsis criteria in Maryland. All the different possibilities that we could have that where we would be giving the fluids. But no, certainly that's fair. For a bit, just for our listeners to go back to why we do what we do, I wanted to cover so giving the high volume of fluid in the shocky patient is useful because we go back to like that cardiac output times systemic vascular resistance. We're fixing the variable that had gone down because of the vasodilation and the leaky vessels, right?
Mm-hmm.
So we're fixing the SVR on that. Similarly,
what you're doing is you're augmenting preload with additional volume.
Yeah.
So thereby you are attempting to increase cardiac output.
Yeah.
By way of increasing stroke volume with preload, increasing stroke volume, and then cardiac output for O2 delivery. You can affect arterial and venous tone with the administration of vasoactive agents.
Yeah, because through alpha activity with the norepi, I guess at least you're getting that vasoconstriction, correct?
Mm-hmm.
Okay. And with that, trying to normalize that map function so that we can get some sort of semblance of normal perfusion going back.
Mm-hmm.
And then after you treat for source control and such, you can fix the root issue and hopefully get them back, away from a disease state. I don't think I had any other questions about that, but I did want to talk about, and maybe I'll remember if I did forget anything. When we were talking on the phone on Friday, you had mentioned this idea of sepsis phenotyping, and you've talked about a couple times today about treating using treatments that are appropriate for your patient. So I'm thinking that those are in the same vein, but I was hoping you could go into some detail about that if you don't have any other points to talk about.
No, I think this is just, we wanted to bring everyone from a listener standpoint, what does the next 5 to 10 years look like in terms of sepsis resuscitation? We'll get smarter with AI and trying to identify patients earlier. We will continue to have new antibiotics per se that come up, and we'll refine antibiotic selection. Hopefully we'll have better methods to continue to assess someone's fluid tolerance and volume responsiveness about getting the right fluids. When we talk overall about sepsis care, we are moving in a direction whereby, when we say phenotyping, what is that individual's host response to infection, and delivering therapies at that individual's response to infection, rather than we're talking about general therapies for all. Some patients manifest a different spectrum of inflammatory mediators and their reaction to infection and their host response to infection. We are learning more and more about that individual's response. And so to that end, there will be evolving therapies within the next decade that we can give and focus and develop individualized sepsis resuscitation pathways, rather than right now we're talking about generalities for all.
And forgive me, I'm not fully understanding. So would that be more so like, again, I'm just spitballing here. So like a patient shows up, they're septic, we'd be able to get like a rapid genetic profile. Is that what you're talking about? Or like
we'd be able to get a profile of what their immune response is and potentially develop and provide immunotherapy directed towards that individual's immune response. What's their cytokine milieu? You and I may have different body reactions if we had the same pneumonia, which means we may require slightly different therapy, even though we've both got a right middle lobe pneumonia.
Wow, that's really interesting. Wow. That was not what I was thinking of. That you've got me thinking now. That's really interesting. Yeah. Hmm. Yeah. I don't even have any questions about that. That's something I'm just going to have to do a deep dive in. Anything else? Anything else we haven't covered about sepsis that you'd like to cover?
I think we've talked about a lot. I hope it's been helpful and informative to all your listeners, and certainly happy if any of them have follow-up questions, comments, concerns to shoot them my way, and we'll do the best we can to get them answered.
Yeah, no, and I really appreciate you coming on. The project has always, the Alert Medic One project has always been rooted in functional physiology, pathophysiology, and taking that step. And because that's my background, I've always, I got my bachelor's in physiology. That's it's helped me. It truly has helped me to do my job better by trying to learn what the underlying physiology is and pathophysiology is, because then it helps me connect the dots, and it's also helped me become a better educator to EMS clinicians. Now, certainly, I don't know what I don't know, and I want to continue my studies in physiology, but I think even knowing a little bit helps capture that 20% that I was talking about earlier, right? So I really appreciate you entertaining those questions and helping clear the picture of sepsis. Did you have any closing comments before I close this out?
Let's see. Key things: early recognition. Be wary of tachypnea. Be wary of those non-specific complaints such as fatigue, generalized weakness, especially in immunocompromised patients and older patients that won't manifest a febrile response. Be thinking about sepsis. If you just take all comers who are sick, more than half it's going to be due to sepsis. And then just think of your common sources: lung 1, genitourinary, intra-abdominal, skin, soft tissue, and then indwelling lines or devices. Provide some fluid, but don't feel compelled to give a large amount of fluid in the absence of sepsis-induced hypoperfusion. Get peripheral pressors started if you need to. From a norepi standpoint, if someone's critically ill, they look moribund, you're given your fluids, go ahead and get peripheral norepi on board to bring up that mean arterial blood pressure, and then, get them safely and quickly to your local emergency department. I think those are some key tenets.
Summarized absolutely perfectly. Hey, do you want to give a shout out to your podcast?
Sure. So for those of you that like continued discussion on the resuscitation of critically ill patients as it pertains to the intersection of emergency medicine and critical care medicine, we do a monthly podcast. It is called Critical Care Perspectives in Emergency Medicine. It is free, and you can find it at ccpem.blog. And you'll hear myself and a few other folks talk about a number of things. We tend to focus on recent cutting-edge articles that are published in the last 1 or 2 months before we record, to bring everybody up to date on what the latest literature is showing in resuscitation and critical care of our sick ED patients.
Perfect. Absolutely. Please check out Dr. Winters and his team. For the folks tuning in today, as always, I sincerely appreciate you all taking the time to listen and give the feedback that you do. Please continue to follow us on our Instagram. If you're a Spotify listener, first, I want to say thank you. We've been pushing to get more followers on Spotify. We just hit, as of October 4th, 2024 at 3:17 p.m., we have 1,001 confirmed followers. And listen, folks, that is jaw-dropping to me. When Ken and I started this in 2018, we had, and Dr. Vipper, when we started this in 2018, we had no idea the spread and the reach that we were going to get. And the fact that you all are actively engaged and are listening and interacting and really getting everyone next to you better by the comments that you all make, we really appreciate that. I truly believe that we're in a renaissance in EMS and in EMS medicine, and we make each other better. So I really appreciate you all listening in. If you have any feedback, questions, please shoot us an email at admin@alertmedic1.com. Continue to follow us on Instagram. And that's going to be it for now. Thank you very much.